Thank you very much for your talk. Very authentic, and your experience really comes through. It is clear your passion, and it was very inspiring. Thank you very much. Our next speaker will come from Florida, from Miami, sorry. He will talk about a good life and a good death, a Hebrew perspective. So, Professor Kinzbrunner.
You gonna get up there, or?
It will get up there, yes.
Yeah, okay.
Once you start,
Here we
it
go.
will be there.
Okay. All right. Thank you, and it's a pleasure to be here, and I want to wish all my co-religionists the Purim Sameach, happy Purim, since today's Purim. So what I want to talk about today is Jewish aspects of end-of-life care. It's something that I've done a lot of in the last decade or so. And I want to just start a little bit with the title, which gave me a good death. Because if we go to the Bible, to Deuteronomy 30:15, it says, "See, I have set before you this day life and good and death and evil." So if God's telling us that life is good and death is evil, how can we say that there's such a thing as a good death? This is something that I've always tried to play with philosophically. I'm not going to spend a lot of time on this. These are some definitions in the literature of what a good death is, and it's really not the goals of the things that we're trying to get done. It's the terminology, I think, that we want to consider perhaps making a little bit different. And so I like, perhaps, instead of a good death, the construct of dying well, which is one of our colleagues, Dr. Arabayek, who's sitting in the audience today. I told him I was giving him a plug for this. The idea is that death is viewed as the final stage of life, and in addition to relieving symptoms, we ask and accept for forgiveness, express love, acknowledge self-worth, and say goodbye. And I just think it's a better description because it takes away any issues around what God is trying to tell us in the Bible vis-a-vis what we're trying to accomplish with our work. So I would just propose a slight change in my title, A Good Life, Dying Well, in Hebrew perspective. So now getting down to business. In Judaism, life is of almost infinite value. We used to say life was of infinite value, but I think as our rabbis are recognizing more and more the importance of palliative care and end-of-life care, they're even admitting that it's almost of infinite value. And it's important because we'll violate many Jewish laws, such as the laws of the Sabbath and holidays, to preserve life, although in many respects, sanctity of life is more important than quality of life overall. Yet, if you go to the book of Koheles, which is Ecclesiastes 3, chapter 3, verses 1 and 2, it says, "To everything there is a season and a time to every purpose under heaven, a time to be born and a time to die." So clearly, Judaism recognizes there is a time to die. In fact, if we go to Jewish sources, we find out, if we look in the Bible, we find out that Jacob, the patriarch of the Jewish people, was actually the first person whose death is described in detail in the Bible. And if you go into Jewish literature, including the Talmud and what we call the Midrash, which are rabbinical tales, it tells us that not only was Jacob the first one to experience illness in which it was described in the Bible, but he was actually the first one to have it. Jacob actually asked God to create illness prior to death so that one could bless one's children before they go, and God said, that's a great idea. You're going to be the first one. And that's why the Bible, in fact, and that's, if you look in the Talmud or in the Midrash, that's exactly what it says. And so Jacob's death is described in detail at the end of the book of Genesis. And it's really, and I always say to people, that's the first hospice death in recorded history. Because he died in the presence of his family and his loved ones. He was able to bless his children and take care of all his business before he passed on. Now, Judaism recognizes terminal illness. I'm not going to spend a lot of time on this. There are two different definitions. One is called treifa, which is a person with a prognosis of 1 year or less. And I always joke that that's more generous than the Medicare hospice benefit, which is 6 months or less. And the second is goses, which is somebody who's actively dying. The Talmud describes that as the last 3 days of illness. The problem with that is you don't know when the last 3 days begin until the person dies. So it's not a practical definition. It's what we call actively dying. And in the Talmud, it even says that these patients have noisy breathing, what we call in our vernacular the death rattle, the upper airway secretions that the patients have difficulty clearing. And the importance of a gosais is that only basic needs can be provided and other interventions are not allowed to happen. When we look at medical ethics, we know these are the cardinal values that are often described. And Judaism, what's happening in Judaism is the rabbis have worked to redefine these values from a Jewish perspective. And with the exception of autonomy, they're really pretty much the same. Where autonomy is different is rather than just saying it's the right of people to choose, if somebody is choosing to follow Jewish law, they voluntarily limit their autonomy so that the decisions they make are consistent with what God wants them to do. But since we don't always know what God wants us to do because the Jewish literature has to catch up with the times, and so we have to go to rabbis who are the experts in God's law to provide us advice and counsel regarding health care decisions. Because what they do is they interpret the Jewish literature and are able to take what's happened in the past and apply it to the present day by analogy. So when we look at end-of-life decision-making, it only applies to patients who are terminally ill. And decisions in Judaism, just like in end-of-life care, are made on a case-by-case basis. Yes, there's law, but you need an expert because there are always exceptions to that law that one can make. So therefore, from a traditional Jewish point of view, one would include the rabbi in their decision-making. So for example, if a Jewish person who follows Jewish law is going to make out an advance directive, as part of that advance directive, they would include consultation with a rabbi. And what's important is having a rabbi who knows healthcare law. And since not every rabbi does, if a rabbi does not, it's incumbent upon that rabbi to contact someone who is conversant with Jewish law, and most rabbis know who those people are. So what I was asked to do is really look at this from the perspective of the work I do. And those of you who know me know that I've been working mostly administratively for the last couple of decades. But I do get a lot of phone calls about various patient problems, especially about problems related to Jewish patients. Thank you. Getting dry. So what I'm going to do is present a case. It's a model of a couple of cases, actually, that I've dealt with, which were issues related to Jewish end-of-life care, and then discuss some of the particular issues. So we have a 75-year-old man who was bedbound following multiple CVAs, cerebrovascular accidents, strokes, complicated by multi-infarct dementia, and he has a history of heart failure. He is able to take food and fluid by mouth with assistance. He is admitted to the hospice program after he develops multiple decubiti, and he does have a DNR order on his chart, which was permission for that was given by the patient's wife, who is his healthcare surrogate. Aggressive wound care has started. He's having pain in the decubiti, in the areas of the decubiti. He had been on Vicodin, and that was switched to morphine suppositories, 10 milligrams every 4 hours around the clock. And about 24 hours later, he became less responsive. Now, the patient and his wife have two sons, one who lives in the same city and has been very involved in his father's care, and one who lives out of town and is not involved. These are all Jewish. There's a Jewish family. The son who lives out of town recently became observant. He just chose to become more observant in his faith, while the rest of the family are primarily secular and non-observant. Jews observe the religion in a wide variety of ways, and some are more observant, some are less observant. But what's really, and we see a lot of this kind of issue where in a family there will be a mix where somebody will become more observant than the family often is, and that sometimes creates conflict, and that's part of why I'm bringing this out this way. The son who lives out of town is the one who called me. And he says he spoke with his rabbi, And based on his conversation with his rabbi, he would like the following things done for his father. One is, since he thinks his father has become unresponsive to the pain medication, he wants all pain medication stopped. He wants the do not resuscitate order removed from his father's chart. Since his father is not responsive and not eating now, he wants IV fluids initiated immediately and wants to discuss the placement of a feeding tube. And he informs me that he already spoke to the hospice nurse about all this, and she didn't want to do any of these things. And he's very concerned. And she tried to explain to him, for example, that she didn't want to do the IV fluid because of heart failure, but nevertheless, she didn't want to stop anything. She was even uncomfortable stopping his pain medication because she was concerned that he would begin to have pain again. So what I want to do now is give you some principles that we're going to work with to figure out what I'm going to tell the son, basically, and how I'm going to try to handle this. So in terms of refusing, withdrawing, withholding care, under Jewish law, terminally ill patients may refuse medical treatment if the treatment is not proven to be effective, is clearly futile, or entails great suffering or significant complications. Withholding is allowed when the intervention will delay the dying process, or the terminally ill patient is experiencing pain and suffering that will not be helped by that intervention. Withdrawal of life support is much more difficult, though, and is generally not allowed unless the intervention is clearly viewed as an impediment to dying. And it's very difficult to make that conclusion about most interventions, including ventilators, which I don't have time to get into now. So withholding is much easier than withdrawing, as opposed to the way secular ethics holds, which is basically today that withholding and withdrawing are equivalent. In terms of the treatment of pain, Judaism does not believe that pain and suffering is a virtue, so you don't have to have pain, and therefore you can find a remedy for the pain. The treatment of physical pain with opioids is therefore mandatory, and they should not be withheld in the face of intractable pain, even if there is concern that death may be hastened, which I think most physicians in the audience, I'm sure, know that based on what we understand about the pharmacology of opioids, that really happens very little, if at all. There are usually other factors involved as well that are causing the problem, and it's not the opioid itself. Judaism also recognizes the importance of treating mental anguish and suffering. CPR may be withheld or refused. If you can look about what we talked about already, and it's because it's ineffective, as far as we know, and it may even cause harm. But what I've learned in speaking with rabbis in the communities is that one of the main reasons they don't want their congregants to have do not resuscitate orders on the chart is not because they think it has to be done to everybody. Some rabbis do, but most, even Orthodox rabbis, will not. The problem is that if a DN order is placed on the chart, they believe the patient will not be treated at all. They believe that it translates from do not resuscitate to do not treat. So one of the things I've learned is if you have a conversation with the rabbi and the family and explain that, and that we will continue to treat the patient appropriately for their medical needs, most of the rabbis will be more comfortable telling their congregant it's okay to agree to that, as long as it's limited to not doing resuscitation. And that's a very, very important thing that I've learned over the years in working with rabbis in many communities. Nutrition and hydration is the trickiest issue because food and fluid are considered basic care by most rabbis. And therefore, even when it's provided artificially, most rabbis don't consider the provision to constitute a medical intervention. That's within the Orthodox world. If you look at rabbis who are not in the Orthodox world, Reform, conservative rabbis, they're more lenient about this and will consider feeding tubes and parenteral hydration to be medical interventions. And this comes from the idea that Rabbi Moshe Feinstein is one of the leading decisors of rabbinical law in the late 20th century. And he gave a ruling once on food and fluid in a terminally ill patient, and there are two translations. One says, quite clearly providing food is beneficial, and the second translation of the same sentence, clearly we must feed him food that will cause him no harm. So what it sets up here is he's saying the beneficence, non-maleficence argument. And so therefore, it gives us some leeway that we should provide food and fluid, but in a fashion that provides benefit and avoids harm. Competent patients can refuse hydration and nutrition, but caregivers should try to convince them it's the right thing to do. And if you can determine that the food or fluid is without benefit or harmful to a particular patient, then you might be able to avoid it, but you need the rabbi who understands the situation fully to be involved. One of the other things I'll tell the physicians here is if you're dealing with a Jewish patient who says, my rabbi said, one of the things you want to do is have the rabbi speak to the rabbi directly, because patients will often filter what they tell their families will filter what they tell the rabbi. So the rabbi needs to know exactly what the medical condition of the patient is and understand that to help make those decisions. So what happened with our case? I spoke to the son, and ultimately we got together and even had ultimately a family meeting about this, where I got everybody on the phone. And we agreed on a few things. We did agree to hold the analgesia to see if the patient would get more alert, having an as-needed opioid dose, a lower dose available if the patient started to experience pain. And then if he became more alert, we would start him on a lower round-the-clock opioid dose with additional medication prior to the decubitus care. And we, in fact, did that, and he tolerated it well. He became back to his same level of response as he had before. We were able to control his pain. I'd also suggested if they were having more difficulty, we could also look at putting some opioid directly into the decubitus, because there are some studies that show that since the decubitus is damaged skin, sometimes the pain medication will get in there somewhat and will help with pain locally, and it's not necessarily systemically absorbed. In terms of the DNR order, since this was the patient's wish and confirmed by his wife, who was his healthcare surrogate, we explained to the son that we would have to respect the wish, because this represents the patient's autonomous desire, despite his and the rabbi's objections, because, in fact, the wife is the one making the final decisions. And again, we're dealing with this non-religious wife and the religious son, and the non-religious wife really doesn't care what the rabbi says, to be perfectly honest. And that happens a lot, and that's why you try to work together with them. And we assured the son and the rabbi that the patient would continue to receive appropriate medical care. And they weren't thrilled, but at least they were comfortable enough with that decision. In terms of nutrition and hydration, we agreed to observe for 24 hours to see if he would become more alert and start to eat again. If he didn't, then we would consider some hydration via hypodermoclysis subcutaneously, no more than a half a liter or so of fluid a day because of his history of heart failure. And then we would reevaluate after 24 to 48 hours. And he did become more responsive and was able to take food by mouth again, as he had before. And so that was actually something that we were able not to have had to deal with. So that's the way we worked out the needs of this patient and those particular issues. And I think I have a couple minutes left. Yes. Okay. So I just very quickly, moving away from the case, just for a couple of minutes, I wanted to mention mourning and bereavement rituals in Judaism, because I think they're very important and they really serve a purpose. There are ritual mourning activities when you lose an immediate relative. So if you lose a parent, you lose a sibling, a child, or a spouse, you're supposed to participate in mourning rituals. There are 4 stages of basically of mourning in Judaism. One is called Ananus, which is the period between death and burial. And during that stage, the bereaved, having just experienced the loss, is responsible to make sure the funeral arrangements are made. That's the primary responsibility. So much that there are certain responsibilities of daily Jewish life related, for example, to prayer, that you're not required to do. So when you're in that period, you actually don't have to go to shul, synagogue, and you don't have to participate in the prayers for that day when you have a loss, because you're supposed to be focusing on arranging the funeral. Then you have the funeral, and the funeral is done usually within 24 hours. The only time we delay is when relatives can't get in, immediate relatives can't get in right away. If they're coming in a day or so, we might postpone it for a day or so. After the funeral, there's Shiva, which under traditional Judaism is 7 days, although there are people who choose to observe for only 1 day or 3 days. And basically, Shiva means 7 in Hebrew and also means sit, because you sit on a low stool close to the ground. There are certain things, activities you're not allowed to do. I don't have time to go through them all right now. And the purpose of it is people come and visit you in the home, and they try to ask you questions about the person you've lost, and it allows you to form memories of the deceased. So it's beginning to help you memorialize your loved one in a way that you can remember them in a most positive way. After Shiva is a period called Shloshim, which is 30 days after burial, and Shiva is included, so you really have only 23 days left. During that, you go back to work. You begin to reintegrate a little bit into your life. There are still some activities related to celebrations that you're not supposed to participate in. And that concludes the formal mourning, except if you lose a parent. If you lose a parent, you actually mourn for an entire 12-month period. And the mourning really is requirements of going to synagogue, reciting the Kaddish, which is we use a memorial prayer, and also, again, avoiding celebratory activities. And what I like about it is if you look at this and you go through these stages, it's a gradual reintegration into society after the loss. So the rabbis really thought about this, and I think really came up with a way to help Jewish people grieve. If you give over yourself to the ritual and follow it along, you see that during that period you memorialize your loved one, and then you gradually reintegrate into society with the change that you've now lost this person. And I think it really is a very healthy model for grief and bereavement, and that's why I chose to present this to close my talk. And I think, one more point. Following mourning and bereavement, we have other activities. One is called the unveiling, when we uncover the headstone. It can take place either after the Shloshim period or at the end of that first year. We yearly memorialize our loss, what we call the Yortzeit, the anniversary of the date of death. Then there are special memorial prayers on certain holidays called Yizkor. And so again, this really helps us memorialize our loved ones, and I think is a very healthy way to go through the grief and bereavement process. Thank you.